Okay, ready? The subcommittee will come to order. The chair will recognize himself for an opening statement. According to data from the Centers for Medicare and Medicaid Services in 2011, Medicare spending accounted for 21% of total national health expenditures. Medicaid makes up another 15% of total NHE. Medicare has been on the Government Accountability Office high-risk list continuously since GAO began designating programs as high-risk in 1990, and it remains there in GAO's February 2013 report entitled High Risk Series and Update. In 2012, Medicare spent approximately $555 billion, caring for more than 49 million beneficiaries. CMS estimates that out of that $555 billion, $44 billion, nearly 8%, were improper payments. The report noted that while Medicare has made progress toward addressing some of GAO's previous concerns and the program's known deficiencies, not enough had been done to warrant its removal from the list. Medicaid entered the high-risk list in 2003 and has also remained there, with total expenditures of $436 billion in 2011 for its approximately 70 million low-income beneficiaries. The Department of Health and Human Services estimates that Medicaid's national improper payment rate is 7.1%. These improper payment figures represent only those payments that CMS knows were improper. Estimates of the real cost of waste, fraud, and abuse in these programs are much higher. In an April 2012 study, former CMS Administrator Donald Berwick and RAND Corporation analyst Andrew Hackbarth estimated that fraud and abuse added as much as $98 billion to Medicare and Medicaid spending in 2011. And without any significant program integrity changes, the Affordable Care Act will add an additional 7 million people to the Medicaid rolls in 2014. By 2022, that number will grow to 11 million new enrollees. The ACA also contains perverse incentives for private insurance companies to ignore waste and fraud, which drives up premiums and copayments for consumers. The ACA's medical loss ratio provision requires health plans to spend 80% for plans in the individual and group market and 85% for large group plans of premium revenue on medical care. Supporters of the MLR claim it was designed to protect consumers from unscrupulous insurance companies. However, under the regulation, investments in fraud detection and even quality improvement and care coordination fall under administrative expenses, which can only make up 20% of a plan's spending. Plans struggling to make the 80 or 85% threshold for medical cost often can't risk these activities, which could save consumers money and provide them with a higher quality of care, for fear of being penalized and having to pay rebates. Even worse, if a plan does identify fraud, cutting those fraudulent payments and activities actually reduces their amount of spending on medical cost, making it even harder for them to reach the 80 or 85% threshold. We are actually exporting the inefficiencies of federal health programs into the private sector. While some here today may champion MLR, it is apparent to me that MLR will not reduce the tens of billions of taxpayer dollars lost each year to improper payments, but rather add to it, and that is a problem. Simply, eliminating waste, fraud, and abuse is not going to put Medicare and Medicaid on solid financial ground, but ignoring the threat it poses to sick Americans cannot be ignored any longer. We have an obligation to use taxpayer funds in the most responsible and efficient ways possible, an obligation we are not currently meeting. I want to thank all of our witnesses for being here today. I look forward to hearing from our GAO witnesses what areas in Medicare and Medicaid programs are most vulnerable to fraud and their recommendations to combat improper payments. I also look forward to hearing from our private sector witnesses about the tools and innovation they use to fight waste, fraud, and abuse on a daily basis. Thank you. And I yield back. The chair now recognizes the ranking member of the Subcommittee on Health, Mr. Pallone, for 5 minutes for an opening statement.
Thank you, Chairman Pitts, and good morning to everyone. Fighting fraud across all healthcare settings is critical. I think we can all agree on that. In fact, this committee has an important role in ensuring that the government is aggressive in addressing long-term solutions to an ongoing threat. And I'm committed to working with my colleagues now and in the future to help support the constant work that must be done to cut waste, fraud, and abuse. But I'm not entirely sure that another hearing on this topic, since one was held less than 3 months ago, is necessary so soon. Instead, I think we should be examining the impact of the looming sequestration, which is just 2 days away. Mr. Waxman and I, along with other senior members of this committee, requested that we look at how sequestration will affect the programs and agencies we oversee. For example, in New Jersey, nearly 4,000 fewer children will receive vaccines for diseases such as measles, mumps, rubella, tetanus, whooping cough, influenza, and hepatitis B due to reduced funding for vaccinations. And the New Jersey State Department of Public Health will lose about $752,000, resulting in around 18,800 fewer HIV tests. These spending cuts not only threaten our economy, but also a range of vital services that I think our time today would be better spent examining. Fraud schemes come in all shapes and sizes and affect all kinds of insurance, public and private alike. Whether it's a sham storefront posing as a legitimate provider, or legitimate businesses billing for services that were never provided, it all has the same result: undermining the integrity of our public health system and driving up health care costs. So for every dollar put into the pockets of criminals or program abusers, a dollar is taken out of the system to provide much-needed care to millions of people, including Medicare seniors. I think we can all agree that a strong commitment to combat health care fraud and abuse was included within the Affordable Care Act. The law contains over 30 anti-fraud provisions to assist CMS, the OIG, and the Justice Department in identifying abusive suppliers and fraudulent billing practices. The most important provisions change the way we fight fraud by heading up the bad actors before they strike and thwarting their enrollment into these federal programs in the first place. In this way, we aren't left chasing a payment once the money's already out the door. And we also made important improvements in the ACA to the False Claims Act, which is another useful tool that can help address fraud and abuse. Today, we'll hear from CMS about the great work already being done. Over the past 4 years, enforcement efforts have recovered $14.9 billion, and I think that's considerable progress. In fact, return on investment for each dollar spent on healthcare-related fraud and abuse investigations in the last 3 years has been $7.90. So we will also hear from the GAO about their high-risk report released this month. That report notes that while we're making positive steps, there is still a lot of area or a number of areas that continue to need improvement. So I know we're going to hear from the panel. I think we must continue to innovate. Bad actors are always going to find loopholes, and it's our job to keep one step ahead of them. Thank you again, Mr. Chairman.
Chair thanks, gentlemen, and now recognizes the Vice Chairman of the Subcommittee, Dr. Burgess, for 5 minutes for opening statement.
Thank you, Mr. Chairman, and I'll acknowledge that members on both sides of the dais have a fundamental sense of fairness about this, and they want to preserve, protect, and defend a program that is there to serve the most vulnerable seniors in our population. I agree with the ranking member that it does seem like we have a lot of hearings about this. I will agree that it doesn't seem that there has been a lot of movement in the right direction. I would disagree that this hearing is not important and we should be focusing on something else, because after all, the sequester would not even be necessary if Congress was doing its job in oversight, if the administration was doing its job and the agencies were doing their job and didn't allow these dollars to be delivered hand over fist to felons and organized crime in the first place. I do feel that the federal government has not done enough to address this issue. Sure, we had a hearing right at the end of the last Congress, the Oversight and Investigations Subcommittee. In fact, we have some of the same witnesses here today. But I got to tell you, it bothers me that we keep having to have these hearings and we don't seem to ever move the needle. I took the liberty of doing a little Google search last night and Googled the name Janet Reno and Medicare fraud. And it turns out in February of 1998, 15 years ago this month, Janet Reno stood in front of the American Hospital Association and said, fraud in the Medicare and Medicaid system is the #1 priority for her Justice Department, and it was going to end with her. Well, here we are 15 years later, and we're having the same discussion. The analysts, the law enforcement officials estimate that 10% of total healthcare expenditures are lost to fraud on an annual basis. And guess what? That 10% is not equally distributed between the public and private parts of our healthcare system. No, the loss falls disproportionately on the part that is under the jurisdiction and control of the federal government. The Government Accountability Office, who we have here with us this morning, and others have said these characteristics are unsustainable. Eliminating waste, fraud, and abuse that hemorrhages billions of dollars from our country's government-run healthcare programs should be the foremost priority of this committee. And again, I'll say it one more time. How can we protect the most vulnerable in our society if we don't protect the integrity of the system that was intended to serve them? If we're serious about bringing down the cost of health care, if we're serious about protecting the patient, if we're serious about avoiding another sequester, if we're serious about fixing the inequities in the payment system for physicians in Medicare, we ought to be all about eliminating this problem and eliminating it in this Congress, not waiting for another Congress, not waiting for another president. The time is now. The private sector has developed ways to combat fraud that really doesn't burden providers or patients. They're able to catch far more incidents of fraudulent activity. The Center for Medicare and Medicaid Services has attempted to develop new efforts to recover funds, but the current system to prevent improper payments is just simply not working. And I know we have some of the same witnesses we had here in December. I'll use the Visa example again. I give my credit card to my staff to go out and buy lunch for our staff at Chick-fil-A last December. I'm called on my cell phone on the House floor. Hey, somebody's trying to charge $100 worth of Chick-fil-A on your credit card. Is that okay? And I affirmed that it was. Why do we not have the same system of safeguards when we spend so many billions of dollars in our healthcare system? Now, in fairness, one of our witnesses, Dr. Baderi, thank you very much for being here this morning, and thank you for coming in to brief my staff and myself earlier in the last Congress. I appreciate the efforts that you have underway. The Government Accountability Office has made recommendations, some dating back years and years, and they failed to be implemented. Well, it begs the question, why is this acceptable? So if we are going to be developing new and innovative approaches to fight fraud, and it's becoming increasingly important that we do so, I do look forward to hearing the testimony from the witnesses today, but let's hear that testimony with in mind the fact that we are going to solve this problem. Thank you, Mr. Chairman, for the indulgence. I'll yield back the balance of my time.
Chair, thank you, gentlemen. Now recognize the ranking member of the full committee, Mr. Waxman, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. I appreciate your holding this hearing today and for focusing on the important topic of healthcare waste, fraud, and abuse. Improving our healthcare system, both private and public, requires pursuing dollars that are wasted or diverted, dollars that add to our costs but don't improve health. I've dedicated much of my career in Congress to improving the quality and efficiency of both the Medicare and Medicaid programs. Fighting fraud is critical to both of these and critical to both being responsible stewards of taxpayers' dollars, an issue where we should be able to achieve bipartisan consensus. I'm very pleased by the recent reports that have highlighted our progress fighting fraud and abuse. According to the administration's most recent report on the Healthcare Fraud and Abuse Control Program, healthcare fraud prevention and enforcement efforts recovered a record $4.2 billion in fiscal year 2012. For each dollar spent on healthcare-related fraud and abuse investigations in the last 3 years, we recovered $7.90, the highest return on investment in the 16-year history of the program. We're now seeing the impact of provisions in the Affordable Care Act that help us move away from the traditional pay and chase approach to a more proactive approach designed to prevent fraud before it occurs. Other administration initiatives, such as implementing the Command Center, which brings together the Centers for Medicare and Medicaid Services, the Office of the Inspector General, and the Federal Bureau of Investigation, and the Healthcare Fraud Prevention and Enforcement Action Team, which is taking action against Medicare fraud and fraud hotspots across the country, are bringing more tools and resources in this fight against fraud. We also need to ensure that the public and private sectors are collaborating, because we know that schemes that affect programs like Medicare and Medicaid often are also perpetrated against private payers as well. The administration has initiated the Healthcare Fraud Prevention Partnership that is bringing together federal and state officials with private insurers and healthcare anti-fraud groups to do just that. The value of these new prevention-oriented approaches is that they target fraud and abuse before it occurs and leverage partnerships across government and the private sector to support this important work. Another tool in the healthcare fraud fighting arsenal, which also is a form of public-private partnership, is the False Claims Act. This law incentivizes private parties to bring suit on behalf of the government to recover fraudulent payments, and has been effective in helping get the federal and state governments reimbursed for a number of high-profile fraud schemes. We cannot rest on our laurels and be satisfied with the current successes in fraud fighting. The data clearly shows that we are moving in the right direction, but just as the fraudsters are constantly looking for the next new scheme, we too must continue our work, and I look forward to hearing from our panel of experts about the opportunities and challenges moving forward. And I want to yield the balance of my time to Ms. Schakowsky.
I thank the gentleman so much, and I appreciate his decades of work to make Medicare, Medicaid, the programs our citizens rely on, more efficient. But I have to say that the passion that I heard from Dr. Burgess, it's as if we don't share that. And I want to set the record straight that we want to and have been cutting the waste, fraud, and abuse, and we need to build on our successes. The $4.2 billion in FY 2012, I think we can start with that and go further. And I also want to say that it's as if the election didn't happen. As I recall, the $716 billion that Democrats were able to save through Obamacare that reduced the cost of Medicare without cutting benefits was used as a sledgehammer accusing Democrats of cutting Medicare. And in fact, we did reduce the cost rather than being applauded for that. At the time, it was used to say that we're the ones that are really taking away something from Medicare beneficiaries, when of course we weren't. So let's get on the same page here. We agree, we all agree, that waste, fraud, and abuse is a problem. We've begun, and let's continue to do something serious about it. Thank you. I yield back.
Chair, thanks, gentlelady. We have two panels for today's hearing. Our first panel, we have Dr. Peter Bodetti, Deputy Administrator and Director at the Center for Program Integrity at CMS, Ms. Kathleen King, and Ms. Carolyn Yoakum, who are both Directors of Healthcare at the Government Accountability Office. Thank you for coming this morning. Your written testimony will be entered into the record. We'll recognize each of you for 5 minutes to summarize your testimony. Dr. Bodetti, you're recognized for 5 minutes for your opening statement.
Good morning, and thank you, Chairman Pitts and Ranking Member Pallone and members of the subcommittee for this invitation to appear before you today. As the Deputy Administrator of the Centers for Medicare and Medicaid Services for Program Integrity and Director of the Center for Program Integrity, I'm now into my third year of having the privilege of overseeing program integrity efforts for the Medicare and Medicaid programs, which is a top priority for this administration and for CMS. And it is an area where I'm very pleased to say that new tools and a collaborative approach are indeed helping us move beyond pay and chase to preventing fraud before it happens. A key component of our fraud fighting approach is what we call the Fraud Prevention System, or FPS. This system, this high-tech system, highly sophisticated system that we put into place in the middle of 2011, analyzes all Medicare fee-for-service claims using risk-based algorithms and generates alerts. CMS and our program integrity contractors can then stop, prevent, and identify improper payments using a variety of administrative tools and actions, including prepayment review, claims denials, payment suspensions, revocation of Medicare billing privileges, and referrals to law enforcement. We have a poster for you here today that demonstrates the initial results from the first year of the implementation of the fraud prevention system. Our numbers show that we did achieve a positive return on investment, saving an estimated $3 for every dollar we spent in the first year, and that we have prevented or identified an estimated $115.4 million in improper payments. In addition, and very importantly, this system generated over 500 new leads for over 500 new fraud investigations and provided new information for over 500 existing fraud investigations. To further enhance our program integrity efforts, we have implemented a risk-based screening process for newly enrolling and revalidating Medicare providers and suppliers. This system is designed to both make it easier for the legitimate providers and suppliers, some 20,000 of whom apply to be able to bill in the Medicare program every month, to make it easier on the enrollment side for them to get into the program, while making it much harder for the bad guys to get in, and makes it easier for us to find the bad guys if they do get in and kick them out. We have implemented the terms of the Affordable Care Act that required us to put into place risk-based screening so that people in the higher risk categories are subject to greater scrutiny prior to their enrollment or revalidation in Medicare. Since March of 2011, our processes have validated or revalidated enrollment for nearly 410,000 Medicare providers, and because of this, we have deactivated some 136,000 enrollments and revoked over 12,000 enrollments that were not appropriate or not timely in the program. We've also made major progress in engaging other federal partners to improve the collaboration in fighting fraud. Thanks to a variety of efforts, federal, state, and local law enforcement healthcare fraud activities are being coordinated more and more, and as you have heard, and as I'll talk about in a second, we are also engaging with our fraud-fighting partners in the private sector to improve the integrity of Medicare and Medicaid. We're working with our state partners to improve and enhance our program integrity activities in the Medicaid program, and we've taken steps to ensure that someone who is caught defrauding the program in one state cannot simply move to another state. We have implemented the Recovery Auditor program in Medicaid, and that has already, the states are already reporting some $95 million in recovered payments in the first phase of implementation of that program. We have been working more closely with law enforcement, both through our new command center, which provides a collaborative environment so that we can work together and not just talk to each other one after the other. And we have had a string of successes in terms of building new models and engaging in new approaches to fighting fraud coming out of our collaboration in the command center. Medicare and Medicaid and healthcare fraud anywhere affects every American by draining critical resources from our healthcare system. The administration has made stopping fraud and improper payments a top priority, and today new tools and a collaborative approach are moving us beyond pay and chase to preventing fraud before it happens. I look forward to continuing to work with you to make Medicare and Medicaid stronger, more effective programs by protecting their integrity and safeguarding taxpayer resources. And I thank you for this opportunity to appear before you, and I'll be happy to answer questions later. Thank you, Mr. Chairman.
Chair thanks, gentlemen, and now recognizes Ms. King for 5 minutes for opening statement.
Chairman Pitts, Ranking Member Pallone, and members of the subcommittee, I'm pleased to be here today to discuss our recent high-risk report on Medicare and Medicaid. I'm joined by my colleagues Carolyn Yoakum and James Cosgrove. For many years, we have designated these programs as high risk because of their size, complexity, and susceptibility to improper payments. Together, these two programs finance vital health care services for nearly 120 million Americans. Ensuring that they function effectively and efficiently should be a high priority. CMS has taken a number of important steps in Medicare to improve payment systems in traditional fee-for-service and Medicare Advantage. For example, CMS has implemented a competitive bidding program for durable medical equipment that pays selected providers at competitively determined prices. To date, it has produced savings while beneficiary access and satisfaction appeared stable in early assessments. However, we have also identified a number of opportunities for CMS to improve and refine payments to encourage appropriate use of services, such as improving the accuracy of payments for Medicare Advantage. With respect to program integrity, CMS has made reducing improper payments one of their key priorities and has made progress in error rate measurement. CMS has also implemented provisions of the Patient Protection and Affordable Care Act to enhance its ability to screen providers before allowing them to enroll in Medicare. This should help prevent providers intent on defrauding the program from gaining entry. It has also implemented a fraud prevention system, which uses analytic methods to screen provider billing and beneficiary utilization data before claims are paid to identify those that are potentially fraudulent. While these are important steps, we have made recommendations to CMS to enhance program integrity, such as identifying measurable performance metrics and goals for the fraud prevention system. With respect to Medicaid, both Congress and the administration have demonstrated commitment and leadership to making Medicaid fiscal and program integrity a priority. I'd like to highlight two areas where there has been some progress but concerns remain. First, with regard to improper payments to providers, some positive steps toward improving transparency and reducing improper payments have been taken in recent years, such as increased guidance to states regarding oversight of providers. However, key challenges remain, including eliminating duplication between CMS and state program integrity efforts, and refocusing national audits on cost-effective approaches. Also, our work has identified areas where CMS could streamline and improve its oversight of states' improper payments. Second, supplemental payments. That is, payments above and beyond regular Medicaid payments for services continue to be a large and growing problem. In fiscal year 2011, states reported spending at least $43 billion on supplemental payments, up from $32 billion in FY 2010. While a variety of actions have helped curb supplemental payment arrangements, gaps in oversight remain. In 2010, CMS implemented new transparency and accountability requirements for certain Medicaid supplemental payments known as disproportionate share or DSH payments. However, similar standards for calculating, reporting, and auditing non-DSH supplemental payments have not been established. Although Medicaid payments are not always limited to the cost of providing Medicaid services, when payments greatly exceed Medicaid costs, it raises questions about their purpose, relation to Medicaid services, and whether such payments contribute to beneficiaries' access to quality care. Congress, HHS, and CMS have taken steps to improve the fiscal integrity of Medicaid. However, more federal oversight is needed, particularly in the areas of addressing improper payments and oversight of supplemental payments. In both cases, CMS oversight has been hampered by data systems that do not provide complete and timely data. Mr. Chairman, this concludes my prepared remarks. I'd be happy to answer questions.
Chair thanks the gentlelady, and now recognize Ms. Yocum for 5 minutes for opening statement.
Chairman Pitts and Ranking Member Pallone and members of the subcommittee. Ms. King and I combined our statements, so I'm available to answer any questions regarding Medicaid.
Thank you. I will now begin questioning and recognize myself 5 minutes for that purpose. Dr. Bedetti, it is often said that CMS uses a pay and chase model to fight fraud in our nation's entitlement programs. That is, CMS will unknowingly process a fraudulent payment and then try to recover payment down the road. My understanding is that CMS still largely operates reactively. Are you aware of any single claim using the fraud prevention system that stopped a claim before it was paid?
Mr. Pitts, the history certainly has been of a predominantly pay and chase approach, and that is what the fraud prevention system is changing. And I'd like to point out something that's really quite different with the fraud prevention system than the way that we've done things in the past, because in the past, most of our screening was done on a single claim by claim basis. And what the fraud prevention system allows us to do, it's triggered by claims that come into the system, but then what happens is we are able to combine not just one claim, but the pattern of claims that we're seeing and the pattern of beneficiaries being served and the pattern of services being billed, as well as lots of other forms of information to produce, if you will, a picture of an entire book of business. And that book of business then is given a risk score, and based upon that risk score, we then are able to take action. And that's what the basis of the $115 million in savings, which includes many ways of stopping the payments. Yes, sir.
So the answer is no.
No, the answer is yes. We have definitely been implementing systems that are stopping payments from going out the door, triggered by incoming claims, but looking at a broader perspective. For example, one of the ways we like to stop payments is to kick somebody out of the program once we've identified the fact that they don't belong in the program.
Thank you. Ms. King, Dr. Bedetti testified before the House Oversight and Government Reform Committee on April 5th, 2011, that most of the $60 billion in improper payments accounted for in 2010 were not, quote, usually fraudulent, nor necessarily payments for inappropriate claims, end quote, but rather indications that errors were made by the provider in filing a claim or inappropriately billing for a service. In that same year, his former boss, Donald Berwick, put the number at $98 billion. Frankly, I haven't seen one indication that CMS truly knows how much it loses each year, much less whether a majority of these payments are not usually fraudulent. Do you agree with Dr. Bedetti's assertion that most of the payments are not fraudulent, but merely billing errors by providers?
Mr. Chairman, I'd like to distinguish between improper payments and potentially fraudulent payments. Improper payments are those payments that should not have been made for any reason, and they include both overpayments and underpayments. And each year, HHS measures the rate of improper payments. It is true that most of the problems related to improper payments are related to inadequate or missing documentation. So a large part of that is they have not supplied the proper documentation, or the documentation is inadequate. But I'd like to point out the difference between improper payments and fraud. There is no measure of fraud in the Medicare program, in part because you can't determine everything that's fraudulent, because a lot of fraud is committed and it doesn't hit the improper payment screens. For example, if I sell my beneficiary number to someone and they use it to obtain services, and those services are billed correctly, they're not going to show up as an improper payment. And fraud is actually only determined by a court of law because it involves a deliberate attempt to deceive and to cheat.
Thank you. Ms. Yocum, in GAO's most recent report, you note that states have increasingly used supplemental payments through sophisticated financing arrangements such as provider taxes. Increased scrutiny of such payments has raised significant concerns from the states who believe they have limited resources to fund their already strained Medicaid programs. Given the drastic expansion of the Medicaid program in 2014, do you not see a further increase in the use of such state funding arrangements?
Mr. Chairman, our work has shown that there has been an increase in the use of supplemental payments, rising from about $23 billion in 2006 up to about $43 billion in 2011. We do have some outstanding recommendations for CMS involving, in particular, the use of non-DISH supplemental payments, which currently there is not enough reporting and transparency regarding their oversight, approval, and use.
Thank you. My time has expired. Chair recognizes the ranking member, Mr. Pallone, 5 minutes for questions.
Thank you, Mr. Chairman. Dr. Bedetti, if Congress fails to act in the next couple days, sequestration will result in a 2% cut in the Medicare funding. And I know that funding for fraud and abuse work is not exempt from this cut. Can you tell me yes or no, though? Is the funding for your program integrity work at CMS exempt from the sequester? Just yes or no?
No, sir. My understanding is it's not exempt.
All right, then can you tell me if your budget takes a 2% cut as required in the sequester, is it logical to assume that this cut will have a negative effect on the staff and activities that are currently being used to fight fraud?
All of our activities, Mr. Pallone, to fight fraud and to reduce improper payments depend upon our resources, and anything that reduces our resources is going to mean that we will have the lowered ability to carry out our mission. Yes.
Or according to your own HCFAC report, fraud and abuse activities have had an 8-to-1 return on investment over the past 3 years. Is it true that a cut to program integrity as a result of the sequester could negatively affect the ability to return fraudulently obtained monies to the Medicare Trust Fund?
That's a serious consideration because what we've learned over the years of the Healthcare Fraud and Abuse Control Program is that the more we do spend looking for fraud, the more we find, and so the return on investment's actually gone up the more we spend. So cutting back would be expected to have just the opposite effect.
Thank you. Now, I wanted to issue, waste, fraud, and abuse are not unique to public programs. It's fair to say that many, if not all, of the fraudulent practices that we're addressing in public programs at the federal and state level are also issues for private health payers, and sharing information and collaboration between the public and private sector are critical to these efforts. So could you tell us about the work CMS is doing to increase collaboration and coordination, both internally between Medicare and Medicaid and externally with private payers?
We have joined with the Attorney General and the Secretary joined together to establish the Public-Private Partnership for Healthcare Fraud Prevention. We have a number of health plans and anti-fraud associations and other private sector partners that we're working together with, as well as state agencies and other law enforcement agencies to work together on a problem. This is in recognition of the fact that actually healthcare fraud knows no boundaries and it attacks everybody. And we have already had the first serious interactions between the parties in the private-public partnership, healthcare fraud prevention partnership, and we're building on that. And the intention is that we will be sharing best practices, data, analytic tools across the public and private sector. This is a very exciting and very important step forward for us to marshal resources throughout the healthcare system to fight fraud.
Thanks. Let me go to Ms. Yoakum and ask her about CMS. CMS, through its Medicaid Integrity Institute and other programs, is working to partner with states and help to build state-level anti-fraud capacity. Can you give us a sense of how they're doing, and are there program oversight activities that CMS has taken that appear to be effective, in your opinion?
So there has been some improvements in the improper payment rate in Medicaid. It has decreased by about 1% and in terms of dollar values from about 21.9 to about 19.2 billion. There is more to be done. Our recommendations and our outstanding work is focusing on having CMS collaborate more with states to both augment their program activities and to support their program activities. our work has found that those collaborative audits have actually been the most successful of the efforts that have happened to date.
Did you want to comment on what I mentioned before in terms of, you know, dealing with the private sector as well, and what they're doing?
I don't think we have work that I can respond to on that.
Okay. All right, thanks so much. I yield back.
Chair, thanks, gentlemen, and now recognize the Vice Chairman of the committee, Dr. Burgess, 5 minutes for questions.
Thank you, Mr. Chairman. Ms. King, let me ask you a quick question that deals with third-party liability payment. Congress intended that Medicaid be the payer of last resort. My staff has been in contact with you about improving Medicaid third-party liability. To what extent do you feel that it is necessary to address this?
Sir, Medicare or Medicaid?
Medicaid.
Improving third-party liability for Medicaid.
GAO's work on third-party liability is pretty dated at this point. We have some studies.
So the
going
answer
on.
would be you think it would be worthwhile to look
Yes.
into this. As I understand, the last report was in 2006,
Correct.
demonstrated a significant problem. Will you be willing to work with my staff to see if we can't move the needle on this one a little bit?
We certainly would.
Thank you. Dr. Budetti, sorry, I can hardly see you. At this committee's last hearing on fraud, we asked the Government Accountability Office to provide a list of recommendations to combat waste, fraud, and abuse in Medicare and Medicaid that had yet to be implemented. So in a sense of fairness, maybe you can give us an update on some of these things. I'm going to ask for really brief answers, like yes or no answers to these questions. Have you implemented the GAO recommendation from February '09 that CMS should expand the types of improper billing practices that are grounds for revoking a home health provider's billing privileges?
Dr. Burgess, I don't have the specifics on the individual programs right in front of me. I can tell you that the vast majority of the GAO recommendations are in some kind of process of our responding to them. But I'd be delighted to give you a specific
wish you
answer
would.
For the record afterwards.
It's a possible no, but maybe an incomplete. Yes or no, have you implemented the GAO recommendation from March of 2010 to require the agency to evaluate RAC audits to correct the vulnerabilities identified in the agency? Those are the recovery audits.
Well, again, I can't speak to the individual one right offhand, but we do have lists. We do track these, and I'll be delighted to get that to you.
I have a list myself, happily,
Good.
and I'm anxious to track this with you because it is important. The GAO makes the recommendations.
Right.
We're here fighting the same problem we fight year after year after year. It's important that we make some progress. Tell you what, in the interest of time, we'll leave the GAO reports, and maybe you can work with my office to get us answers. Now, it's referenced several times under the President's Affordable Care Act, under Subtitle E, Medicare, Medicaid, CHIP program integrity provisions, several provisions that were signed into law by the President. Maybe we can just briefly run through those, and you can tell me if those have been implemented. The face-to-face encounter with a patient that's required before a physician may certify eligibility for durable medical equipment.
I believe that one has been implemented, but
So that's a yes.
I believe
Ding,
that's
ding,
a
ding.
yes.
Good for you. Implement criminal background checks for fingerprinting for providers and suppliers considered at risk.
We have not finished the implementation of that for a number of reasons, in part related to the FBI's own internal re-awarding of its contracts, but we are in the process, very much in the process of putting that into place, sir.
It's been almost 3 years since this was signed into law. It's important stuff.
That's
I
correct.
get the FBI and the Justice Department engaged because it was felt to be important by the President. He signed it into law. Let's see that it's implemented. How about implementing limitations on how much high-risk providers and suppliers can bill the Medicare program within the first year?
We are in the process of developing the
So that's an
implementation of
incomplete.
that.
How about implementing a temporary moratorium for new Medicare providers from enrolling and billing the Medicare program, even though there are more than enough suppliers to furnish health care services in certain areas of the country?
That's a very important tool. We've been looking very carefully at the places to implement it, and we are in the process of moving forward with that. where we think it's appropriate as an adjunct to all of the other tools.
Well,
But,
important
not
tool,
yet.
but it's
We have not implemented a moratorium yet, is the straight
it's
answer.
languishing, and it's been we're coming up on 3 years. Establish a compliance program for fee-for-service providers and suppliers.
We are still in the process of working on that, in part because the Inspector General has long since had very sound guidance for providers for voluntary compliance programs. And we
Okay, I'm
wanna,
running out of time.
build on that.
That's also an incomplete. Implement a surety bond on home health agencies and certain other providers of services and supplies.
The surety bond program is in place for DME, but we're still in the process of implementing it beyond that.
For home health specifically, that's a no. And then what about implementing checks to make sure that a physician actually referred a Medicare beneficiary for medical service before paying the claim?
We do have processes in place that are doing that.
Incomplete. So one out of those 7 things that were signed into law by the president that are always referenced as, hey, these are important things that we want the Affordable Care Act to do to combat fraud, we're still waiting to see if they, in fact, will be effective. But thank you, Mr. Chairman. You've been generous. I'll yield back.
Chair thanks the gentleman, and now recognize the gentleman from Texas, Mr. Green, 5 minutes for questions.
Thank you, Mr. Chairman, for the time, and I appreciate our panel has taken the time to be here today. The rising cost of health care threatens our nation's economy and puts more and more families at financial risk. Although I have to say that I just read an interesting article in Time Magazine last week that said Medicare is the ultimate cost saver in health care, but that's not part of my questions. But I believe that a key part of saving money is keeping people healthier longer. To achieve this, people must have the health care coverage necessary that they can be seen when they first get sick and not have to wait until it's so bad they need urgent care. My question is to the GAO and the CMS. Can the Government Accountability Office or CMS estimate the government or private sector costs from the administrative waste associated with the phenomenon in Medicaid known as the churn, where people who are eligible for Medicaid are discharged from their roles for bureaucratic or paperwork reasons or for some temporary changes in income that do not impact their long-term eligibility for Medicaid? Is there any studies that y'all been able to do on that?
We have not done any studies in that area. We've taken a brief look at express lane eligibility and the extent to which that is a potential benefit. There are a few states that have reported some cost savings. From our perspective, those savings always have to be offset by ensuring that eligibility is correctly calculated.
Well, and I agree, and I know a lot of states have a 6-month eligibility, and if you have a senior citizen who forgets to return the letter, you know, instead of being treated for diabetes, they'll end up with an episode and end up even costing more. Again, the GAO and CMS, can GAO and CMS describe the cost to state and federal budget associated with the ongoing determinations of whether people are eligible for Medicaid? For example, my state requires people on Medicaid to be determined eligibility every 6 months, and despite the fact that most people who are on Medicaid are eligible for the program for a much longer period of time, and it requires adult Texans on Medicaid to show up in person for the redetermination. And I know we can cut our Medicaid rolls by making that happen. The problem is that increase our cost by making someone who may be so ill or a senior citizen drop off and then get back on. Is there any quantification of that?
We have not done any quantification of the costs and benefits associated with that.
Okay, because I know on a state level oftentimes they can quantify that if they do this, this will cut our rolls X amount, but in the long run, those folks who are typically so ill, they will be back on and much more costly. I'd sure appreciate if there was an option on that. My last question to the GAO, where should we assign the government expenditures for the following hypothetical? A Medicaid beneficiary with diabetes eligible for or enrolled in Medicaid is removed from the rolls because he or she failed to respond to a letter sent by the state to confirm their residency at a particular address. 2 months later, that person has a diabetic event because the diabetes went unmanaged, is re-enrolled in Medicaid at the time, and now the cost of more expensive inpatient and emergency care is billed to Medicaid. If that person were just covered by Medicaid for those 2 months, it would be more likely we wouldn't have seen those episodic costs. In your opinion, should these added cost be categorized as waste, fraud, and abuse? And if not, where should we categorize that excessive waste and unnecessary and avoidable spending?
Sir, certainly getting care earlier is always beneficial to the patient. Our work on preventive services and taking a look at trying to balance costs and benefits, it's difficult to come up with an exact measure of cost and or savings, and I don't believe that GAO has done that.
Okay. Well, I understand, and I have a couple seconds left. The private sector and some of the studies we've seen, both from businesses who provide the health care, can show that they can save money for that continuing care or that continuing much more reasonable maintenance of an illness instead of waiting for that episode. So, Mr. Chairman, I would hope we would look at that not only from the private sector, but also for Medicaid and Medicare. And I appreciate the time. I'll yield back.
Chair thanks the gentleman. Now recognize the gentleman from Louisiana, Dr. Cassidy. 5 minutes for questions.
Hey, sir. Tagging off of what Mr. Pallone said. Now, in your testimony, you say that for every $1 spent, the program saves $790. And it begs the question that if you have to take a 2% across-the-board cut, why are they going to cut the programs that would save you $7.90 per dollar spent? Is the management so inconsiderate of return on investment that they are going to save something which saves $7, that they're going to cut something that saves $7.90 per dollar spent? That's the testimony you suggested.
Dr. Cassidy, thank you for that question. As you know, the specific cuts related to the sequester have not occurred yet. There's been a lot of internal planning and preparation for the way to do any cuts if they should take effect.
But I have limited time, so if the
Okay.
taxpayer's listening and the taxpayer's wondering what kind of management would cut a program which has an ROI of $7.90 per dollar spent, and that's your testimony, what was management thinking that this would even be on the table?
Well, what I would say, sir, is that the thinking is that what our number one priority is making sure that beneficiaries get the medical care that they need. And if we have
But clearly, if Mr.
we have to
Pallone is
allocate-
right, that the money you save goes back into the trust fund in order to support that medical care, I think the taxpayer has every right to wonder what in the heck she's spending money for. If we are cutting something with an ROI of $7.90 per dollar spent, do you see my concern?
I do see your concern. I also know that in the immediate short term, we have to worry about our principal mission, which is making sure that beneficiaries get
So there's
medical
nothing
care.
else that can be cut between actually paying for medical services and something which gives you an ROI of $7.90 per
There
dollar
are very
spent?
few things that have been exempted under the terms of the
I will tell you, it
sequester, as I
calls into
understand.
question the wisdom of your management. Secondly, you make a sense, you create the impression that if we cut under the sequester all these valuable things, but then what Dr. Burgess just brought up, which I'm sure is because of his staff's good homework, not his own, that only one out of 7 of these things demanded by the Affordable Care Act, which passed in 2010, has been fully implemented. It doesn't seem like a sequester cut now is going to be that which is fatal to their implementation. It actually seems as if there's kind of a casual timeline anyway.
Sir, I'd point out that there are a few more pages of provisions that actually have been implemented that
But I'm speaking specifically about waste, fraud, and abuse.
that's exactly what I'm talking about. We have implemented many provisions in the Affordable Care Act that have greatly strengthened our ability to fight waste, fraud, and abuse. And in doing so, we always have to establish our priorities and allocate our resources appropriately.
Well, if
the
we're going to
highest
establish
priorities.
priorities, then I would suggest that the taxpayer would like that you continue to spend money which gives you a $7.90 return on investment per dollar spent. Now let me move on.
Sure.
And I don't mean to grill, but this is obviously the process. We're all familiar with the New Yorker article about McAllen, Texas, how in CMS's, under Medicare, the hospital in McAllen spent 180% of a cohort spent, of the amount spent on a cohort in El Paso. There's a follow-up article on that in Health Affairs in which Blue Cross Blue Shield patients, Texas Blue Cross Blue Shield, 7% less was spent for the cohort in McAllen than in El Paso. Under CMS, it's 180% more, On Blue Cross Blue Shield, it's 7% less. It seems like the problem may not be the docs, the patients, or the hospital, but it may be CMS's systems. Just looking at the contrast between the two payers and the results they get. What comment would you have on that?
I'd say that one of the advantages of our having established the strike forces under the joint Department of Justice and Health and Human Services aegis has been to look at the highest fraud areas very carefully.
But why did Blue Cross Blue Shield figure this
way.
out prospectively, and we're having to do strike forces to get it retrospectively?
The populations that are being served, sir, are very different. The situations are very
64
different.
years old and 65 years old, these are the same patients in the same hospitals with the same doctors. Again, this seems somewhat of an indictment upon the system because there's not that much difference, I'm a doc, between someone 64 and 65.
I don't have a specific answer for you on that in that area. I'd be happy to look, for anything more specific. But I will say that that we are focusing on the high fraud areas, and we are making major progress in identifying discrepancies like that and working together with law enforcement and with the private sector to do something about it.
Thank you for your testimony. I yield back.
Thank you, sir.
Chair, thanks, gentlemen. Now recognize the gentlelady from California, Ms. Capps, for 5 minutes for questions.
Thank you, Mr. Chairman. Again, thank the panelists for being here today. Dr. Biadetti, Dr. Burgess asked about several projects CMS is implementing from the Affordable Care Act, and you didn't really have time to address them. Would you like to take a minute now to tell us what CMS has been implementing from the ACA?
There are many provisions of the Affordable Care Act that we have implemented. Some of the biggest ones involve the risk-based screening of providers and suppliers, which is a new way of identifying the suppliers and providers that are in the limited risk group and are subjected to very detailed background checks, but not to the same level of scrutiny as others. That's a very extensive program. We've established a program to alert states when someone is suspended or is terminated by one Medicaid program or by Medicare for cause, so that other states can keep them from entering their program. That's an important step forward. We've implemented a number of aspects of our collaboration with law enforcement that have really moved things forward on that front. There are many provisions of the Affordable Care Act that have strengthened our ability to fight fraud and waste and abuse, and we've implemented a great number of them.
Thank you. You know, the hearing is about fraud, waste, and abuse. We know these are significant problems for both public and private healthcare payers. The scope and complexity of healthcare itself, as well as the diverse payers and the systems we have to pay for it, certainly adds to the challenge. Both CMS and GAO acknowledge that we don't really know the true scope and cost of waste, fraud, and abuse to the federal government. My question has to do with how we can begin to get our hands around measuring the scope and the extent of the problem. Unless we do, we won't really know how to tackle it or how much to expend doing that. In that context, how do we measure the effectiveness of the efforts being undertaken now, just some of the programs that you just described?
Sure. We have taken steps towards developing the methodology for measuring probable fraud. We intend to implement that in one particular arena, which is home health, and to apply that methodology. It involves a very sophisticated approach because, as Ms. King pointed out, people don't often volunteer that they've committed fraud, so we can't do a simple survey. But we have made substantial progress towards having a methodology in place to estimate probable fraud. We intend to do that first in home health, and then once we've learned how well that works, to apply it to other areas. We have done a very thorough job in the government of measuring improper payments, and improper payments encompass a wide range of reasons why a certain payment should not have been made, we would very much like to move forward with a reliable measure of probable fraud.
One sort of parallel question that hasn't been brought up, measuring the impact of prevention. That's my background, public health. This is really hard to measure in any way. Can you share some of the metrics and benchmarks that you're using or working on in the area of preventive health?
Sure. And I appreciate the question very much. I think the best way to illustrate it is with an example. When we put into place one of our models in the fraud prevention system, we identified a pattern of behavior that raised very strong suspicions, and we ended up identifying a particular potential fraudster who fell into the same pattern that others had perpetrated. Others had billed hundreds of thousands of dollars or even millions of dollars to the program, but this particular one, I believe, had only billed us for $4,000. But it was the same scam, and it was clear that they were just starting up and getting going. And so we're faced with the question of, how do we take credit for finding something that had only billed us for $4,000? Now, that's exactly where we want to be. I mean, I'd rather it be at $2,000, but $4,000 is a lot better than $4 million. But yet, if we just say that we stopped something that prevented that when somebody had already billed us for $4,000, doesn't sound very impressive. So we have to figure out the best way to put, as the statute requires us, to put a dollar value on prevention. And that's a challenge, but we're taking it on.
I appreciate that. Thank you very much. And I yield back.
Chair thanks, gentlelady. And I recognize the gentleman from Illinois, Mr. Shimkus, 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate the folks joining us today. And I'm not sure if it was Ms. Yoakum or Ms. King who made the statement of trying to define improper payments from fraudulent payments. Who, Ms.
That
King?
would be me.
Yeah, and you know, we're almost in like bizarro world a little bit, because improper payments, fraudulent payments, theft, abuse. Dr. Borghetti, when you mentioned this $4,000 following this scheme of abuse, you know, that's what credit card companies do every day. Dr. Burgess is right. Now, I know, sir, you've done a pilot program on the magnetic strip card, identification card. I think it was in Indiana. Not a lot of fraud there. One, I would ask if we could get a release of the findings of that pilot program. Also, you know, I've also been involved in the, you know, the magnetic chip issue. There was a bill last year by Mr. Gerlach. I would encourage all my colleagues to look at that bill from last year, 2925. It'll probably get reintroduced this year. If major financial institutions can call someone and ask about an improper payment that's outside their area within 12 hours of the payment being made, for the life of me, I don't understand why that's not a good system to help us identify improper payments and fraudulent payments. The billing on both ends, a statement released. Well, that's why we have a bill, because we don't think you've effectively looked at it. And we're slow, we're bureaucratic, we're not the private sector, and we just can't seem to get it done. And that hurts the payments to other folks. So that's my statement more, that there's another bill coming to try to get us to move to a current world technology of a payment system that will help identify improper and fraudulent payments. Let me give you a real crisis in Medicaid is the funding. That's why these hearings are important. But in Illinois, we have $1.922 billion in backlog of unpaid bills that are sitting in our comptroller's office. There's another $700 million worth of bills that are being held by the state government before they give them to the comptroller, which then you add those up, that's $2.6 billion in unpaid Medicaid reimbursements to our providers. The delay in payment is 3 to 8 months. And of course, when they do pay, they're paying 70% of what the private sector is paying for the health care delivery. We are a disaster in Medicaid reimbursement to our health care providers. Some, the smaller ones, going broke or just saying we can't provide Medicaid anymore. Having said that, I know that, Ms. Yocum, the biggest challenge to the Medicaid program through federal initiatives is a lag in Medicaid data from the states. And that you have reviewed the discrepancy in the data from states and reported that CMS will need more reliable data for assessing expenditures and measuring performance in the Medicaid program. I would encourage you to get current data on Illinois. Can you please outline the GAO work on aligning the state's expenditure data, which in your 2012 October report showed significant discrepancies and reported expenditures of more than $40 billion for fiscal year 2009. Even in Washington, $40 billion is a bad discrepancy of reporting on payments.
Yes, sir. We did take a look at 2 expenditure systems that CMS operates. The first is an expenditure system that is the basis with which states claim their federal match. The second is a statistical system that takes the activities performed in a Medicaid program and looks at them from the perspective of the beneficiary. So it is beneficiary-specific payments. These 2 systems are not measuring the same thing, so there is some acceptance that they should be different. But we could not quantify the source of all the differences or the reasons why those differences occurred. At the end of the day, we ended up with about a 90% national match, but on the state-by-state basis, there was significant variation across the different, in terms of the 2 systems.
Thank you, Mr. Chairman.
Chair thanks, gentlemen. Now recognize the gentlelady from Illinois, Ms. Schakowsky, 5 minutes for questions.
Thank you, Mr. Chairman. There was an earlier discussion about McAllen, Texas, and CMS's anti-fraud activities to root out fraud and unnecessary spending. Dr. Vedetti, you mentioned the HEAT task force as catching fraud on the back end. But isn't it also true that many of the Affordable Care Act provisions you are implementing are catching fraud on the front end? For example, the fraud prevention system, the new provider screening requirements, the cross-checking between bad providers and Medicare and Medicaid. So is it not accurate to say that so my sense is that it's not accurate to say that you are doing nothing in these high fraud areas on the front end. And I wondered if you could talk about how the front end prevention is paying off.
Thank you, Ms. Schakowsky. One of the things that I am extremely pleased with is our
Somebody's hitting the mic.
is our growing collaboration with law enforcement. Our law enforcement colleagues are very fond of saying that they don't believe that they can prosecute their way out of the current fraud situation after the fact. And so they've been very active partnering with us on the prevention side and on the early detection side as well. And we have agents from both the Office of Inspector General and the FBI who are assigned to work directly with us and who have been very much involved in helping us build the fraud prevention system and the models in the fraud prevention system and how to follow up on it. And when we do that, we're taking an across-the-board approach, which says we want to stop as much as we can before it ever happens, and that is what we're able to do with activities under the fraud prevention system. We want to catch it early and take administrative action, because it's not, if somebody's only stolen, say, $4,000, that may not very well not be a case that law enforcement could ever pursue because of resources. But then we also want to work together when, in fact, some people do squeeze through, and we have to chase after them after the fact. But so our approach is to shift to moving beyond pay and chase, but we cannot eliminate pay and chase in that sense.
I wanted to ask you also about I feel like sometimes we overlook the importance of that beneficiaries can play in fighting fraud, and I'm wondering if you could discuss how Medicare beneficiaries can help CMS identify fraud, and what steps CMS may have taken to make it easier for beneficiaries to spot fraud or errors.
So I don't know if any of the members of the subcommittee have looked at their explanations of benefits recently, but when I got to CMS and we were reviewing the Medicare summary notices, we decided that we could do a better job of communicating both what the content was and the ability to highlight where there might be problems. And so over a period of time, working with focus groups, with Medicare beneficiaries, and redesigning the Medicare summary notice, we have now produced a new statement that is going out for the first time this year. It's been available for people who get their summary notices online previously, but it's now going into the mail, and this will be much easier to read and much easier for individuals to look to see whether or not there is a problem with their with the billing that's attributed to their having gotten services, and be able to raise questions. In responding to that, we have also vastly upgraded and made much more user-friendly the 1-800 Medicare call system way of dealing with calls that come in that raise questions about possible fraud. And last year, something like 50,000 of the calls that came in led to some level of escalation of our investigation to look behind an incoming call. So on both the summary notices and on the changes to the 1-800 Medicare call system, and on top of that, to our outreach to Medicare beneficiaries to inform them about these changes, we're very much engaging, because our feeling is that 45 million, 50 million beneficiaries out there fighting fraud with us is one of the best ways to do it.
Let me just say, I'd love to see an example or two of this savings from beneficiaries.
I'd be happy to.
Thank you.
Thank you.
Chair thanks gentlelady. Now recognize the gentleman from Kentucky, Mr. Guthrie, 5 minutes for questions.
Thank you, Mr. Chairman. Thank you for coming, and I appreciate you having this hearing on waste, fraud, and abuse within the Medicare system, and hope we continue to explore this. But before I begin my questions, I'd just like to bring out to the committee's attention a company in Kentucky that has a plan to bring savings to the Medicare program through the home health program integrity measures. The industry's 2010 proposal to limit outlier payments has been successful and saved the program roughly $900 million per year in the first 2 years alone. Almost Family's proposal will build on that, and that includes episode limits per beneficiary to get at the bad actors who are billing for lengthy episodes of care in excess of 3 or 4 per beneficiary. Estimates predict this would save Medicare nearly $1 billion per year. We should look at this and other industry proposals in a way to save money within the system and get the bad actors that are fraudulently draining Medicare dollars. I found a lot of industries who are the good actors who are trying to do service and do things correctly immediately want to point out the bad actors, because that affects that affects the whole Medicaid and Medicare program. I do have a question for Ms. Yoakum and Dr. Budetti. I'm interested in reviewing how the states use the funds that in the healthcare law related to Medicaid IT payments. As you know, states are eligible to receive a 90% match from the federal government for the design and development of new systems through 2015. Has GAO initiated any integrity review of these funds and how they're expended to date?
We have not instituted an integrity review of the 90-10 matching states. There's been interest in that, and I believe we are planning to respond to that interest.
What are you doing now with CMS and doing to ensure this is a significant funding stream that states are being used appropriately? How are you managing that? I know you don't have a GAO study or an initiative, but how are you managing that to make sure it's being spent appropriately?
We're working very closely with the states and encouraging the states to implement their advances in data systems and technology, because that's a major aspect of oversight of the Medicaid program. If you'd like more details on that, I'd be happy to get you a substantial amount of information on just what our approach is. But yes, we do believe that having adequate and sophisticated data systems at the state level that can both analyze data and supply data better to the federal government that we need for oversight is one of our top priorities.
Thank you for that answer. And I do have 2.5 minutes I can yield, or yield to Dr. Burgess.
Dr. Burgess.
I appreciate the gentleman for yielding. Dr. Budetti, let me just ask you a couple of questions along the lines that Ms. Chakowski was just asking. First off, do you have an app for that? Well, you talked about your new explanation of benefits and forms that you were providing people.
Well, that's a very interesting question, Dr. Burgess, because we've been looking into that possibility.
Well,
So
I did a little research sitting here at the dais,
Okay.
and I typed the word Medicare into the App Store, and you don't have one, but other people do. And it just seems, knowing how the way the world works, most people who get to the age where they're signing up for Medicare are going to be asking their 12-year-old grandson to help them navigate the smartphone. It may be something that's worth looking into. I thank the gentleman for yielding, and I'll yield back.
In my case, I'll rely on my 17-year-old grandson and my 5-year-old and my 4-year-olds.
Great.
Chair thanks the gentleman and recognize the gentlelady, Dr. Christensen. 5 minutes for questions.
Thank you, Mr. Chairman, and welcome to the panelists this morning. I want to follow up also on Congresswoman Schakowsky's question, and I'm glad to know that the notices to beneficiaries have improved. I'm sure they've improved a lot over the 16 years that I haven't been having to explain them. And you pretty much answered how beneficiaries can help detect fraud. And I know that many seniors are just as concerned as we are with program integrity and are glad to help in fighting fraud. My constituents participate in the Senior Medicare Patrol program, and they seem to be very active. How widespread is this program across the states and territories, and has it shown itself to be helpful in ensuring or reporting and helping program integrity?
Dr. Christensen, when I got to my job at CMS, I decided that one thing we should do was invent the Senior Medicare Patrol, and then I found out it already existed. And so we worked very closely to help expand the resources available to the Senior Medicare Patrol for the first couple of years that I was on the job. It does extend to all states. There are programs operating, and I believe all through the territories as well. It does involve many Medicare beneficiaries, and they receive extensive training in how to help seniors protect their identities, how to identify problems with potential fraud or abuse, and what to do about it and how to report it. So we consider this a very strong adjunct program of ours, and we've taken a lot of initiative in helping to support that program.
Thank you. And I have a provider question as a person who's practiced medicine for more than 20 years before coming here. And having heard from my colleagues back then, but also more so since I've been here, about sometimes overzealous investigations and sometimes unwarranted investigations. But I'm very interested in ensuring, like my colleagues are, that efforts to fight fraud are effective, but also that they're fair to providers, especially those providing care to our nation's most underserved communities who are sicker and where there are fewer resources. And I just want to say for the record, of course, and I'm sure you will agree, that the vast majority of providers are honest actors who are not causing problems. I'd like to find out what CMS is doing to ensure that providers are your partners and not necessarily adversaries, and how effectively are you able to distinguish between who the bad actors and the good guys, so that some of my colleagues or former colleagues are not feeling that they're being treated unfairly in some of these investigations?
First of all, this is a very high priority for us. I mentioned early on that we want to make the system easier and more efficient for the legitimate and vast majority of providers, while making it much harder and more likely to spot the ones who don't belong in the program. And along those lines, I will give you one example that in developing improvements in our enrollment processes, we worked very closely with the provider community. There is a long list of changes that we made to the enrollment system that came specifically out of group meetings that we had with providers, working side by side with them to have them demonstrate to us online what the problems were that they were having with our system, so that we could implement a fix to that problem. So that's been a big part of it. We've gotten a lot of positive feedback from the provider community in doing that. And in terms of the audits and the potential for problems, one of the big advantages of moving the Medicare and Medicaid program integrity operations together, programs together into the Center for Program Integrity is it's allowing us to pursue coordination and integration of a wide range of audits precisely for that reason, to make sure that we're doing the job, but we're doing it as respectfully and appropriately as possible.
Thank you. And on the enrollment, I understand you're transitioning away from paper-based system of provider enrollment. Do you feel that you're able to capture the rural providers and some of those providers in, that are in the poor urban communities as well?
That's a
and
very
a
important
special outreach being done.
That's a very important consideration, and I will. I know that we've worked with large groups, but I will be sure that we'll check on what our outreach efforts have been.
Thank you. Thank you, Mr. Chairman. I
Chair,
yield back.
thanks, gentlelady. Now recognize gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you very much. I'd like to pick up where Dr. Christensen left off, because some of my providers don't feel like there's much of a partnership going on. And I would direct your attention specifically to the RAC program, where I'm advised that the American Hospital Association, based on self-reported data, indicates that nationally 74% of the appeals are being overturned in favor of the hospitals when this comes up. And apparently in my region it's 78%. And it would seem to me, I mean, one of the problems that they're having is they feel like these independent contractors are taking the money and saying, wait a minute, we're not going to release this unless you go through the process, push it to the end, and then if you win in the end, you'll get your money. And so this is a real concern for them, because while we all want to get the bad guys, the hospitals, by and large, in my district are not the bad guys. They're the good guys. And I may not know of some exception to that rule, but I think they're all pretty good providers and are trying to do the best they can. And 78% being overturned on appeal indicates there's a problem in the system. Wouldn't you agree?
So, Mr. Griffith, I will say that we want to get it right, and we want to get it right for the good guys, and we want it to be as efficient as possible. The very high, we have heard some very high appeals successes, but it's only of a small fraction of total RAC determination. So when appealed, the overturn rate seems to be growing, but still only a very small fraction of total RAC determinations are being appealed in the first place. But having said that, we do want to get it right, and so we've put into place a number of checks to look back at what the guidance is that's going to the recovery auditors, what the number of documents that they're able to request. There are a lot of things that we're doing to make sure that the system is working just as you said.
I would encourage you to do that. I would say, you know, I don't come from a medical background. I was a country lawyer, and most of the time when people lose, if it's close, they don't appeal, and I understand that. When they appeal, it means that they really think they've been treated wrongly. That being said, in my profession, if you had a 78% turnover rate, you'd have a judge being removed. And that's what I'm looking at is that, you know, in this case, if we can't get it straightened out, we may have to look at a different system, because that's not fair to the medical providers. And so I do appreciate that. Also, one of the other complaints they have that ought to be simple to fix is when they're denied, they get a letter. But when they win or they get it overturned, they don't get a letter. So all of a sudden, a check comes in, and they have to track down, why did we get this check? Sure would be nice if there was a tracking number or a letter that came with that said, we've decided you were right, and here's your check. Can you fix that?
I will make every effort to look into that, sir. I've initiated a number of actions to, shall we say, improve our communications, and I'll put this on the list. Thank you.
Sir, and if I might add.
Yes, ma'am.
There has been a change in the design of the RAC program so that if the provider wins on appeal, the RAC doesn't get to keep the contingency payment. And that's a change from earlier. And I'd also add that we have been asked to look into, and we have work underway now, that looks at what's happening in post-payment review and the coordination of those contractors that are doing that and whether there's duplication, and also to look at the communications that they're issuing. So we'll have something to say on that later this year.
Well, I really appreciate that and hope that you all will continue to work to make this an easier process for the providers that are just trying to do what they do, and that is to help heal people. That being said, let me shift gears slightly and just ask if there isn't more you can do in the private sector. In our area, we have, I represent Southwest Virginia, which includes a big chunk of Appalachia, and we've had a problem with abusive drug usage. And some of the private companies are doing things that actually work to stop that, such as they have one they call the lock-in program, where if somebody's abusing, they don't stop giving them drugs if they need help, but they don't let them go from doctor to doctor. They're locked in. Can we do things like that to try to look and see what the private sector is doing, like the lock-in program? And there are others that I have here, but my time's running out.
We have been looking at what the options are, because we agree that where there are problems such as the ones that you mentioned, we should look to do the most we can. I will say that the constraints that we have, certain rules that do or do not apply in the Medicare program, we may have different options in terms of what we can pursue. I don't know if you've looked at this or not.
Well, and let me just say
We have
this.
actually looked at it, and we have made recommendations that CMS consider that, and I think their response back to us has been that they believe there are some legal restrictions.
Well, let's just say you're at the right place to get those legal restrictions changed, and if you need something that helps catch the bad guys but makes it easier on the healthcare providers, we'd be glad to oblige.
Chair thanks the gentleman. Gentleman yields back. Chair recognizes Ms. Elmers, gentlelady from North Carolina, 5 minutes for question.
Thank you, Mr. Chairman, and thank you to the panel. I have a couple of questions for you, and I'm probably going to run out of time. So I would ask that I be able to submit some of my questions to you and that you would be able to give me a written response within a reasonable amount of time. Would that be agreeable
Absolutely.
to you?
We'd be delighted to do that.
Wonderful. Well, let me start off with one question. And Ms. Yoakum, I think this question is best suited to you, but feel free for anyone to answer. Back in 2008, when Congress passed Section 1940, as amended to the Social Security Act, Section 1940 required the Department of Health and Human Services through CMS to ensure that each of the 50 states implement an electronic assessment verification system for their Medicaid programs to ensure current and future beneficiaries meet the eligibility standards to qualify for assistance. My question for you is, since that time, being that 5 years have passed now, how many states have fully implemented this program?
I may have to provide that for the record. We did do work looking at that for long-term care eligibility, and I believe it wasn't all states yet.
Okay, well, my understanding, based on the information that I have, is that there is one state out of 50 that has put this in place, and that is the state of Florida.
Yeah.
That is an incredible amount of time for this process to not have been put in place. And, you know, for me in North Carolina, this is significant. Why is it important to us? Because the cost that you know, because the system isn't put in place, you know, the losses that our state is facing are about $275,000. At this point, obviously, 5 years in the process, this should have been put in place. So I guess I would ask, what is standing in the way of that? What possible reason could there be that only one state be fully implementing this process?
Again, we'll provide additional for the record, but I
Okay.
do believe that a lot of it is around the data systems in Medicaid and the need for them to be upgraded and improved.
Okay, well, my next question, I'm going to shift gears a little bit here, and I don't know, Dr. Bedetti, this might be a question best suited for you. In the durable medical equipment competitive bidding process, one of my questions is for those facilities that you know have the durable medical equipment. The number of audits has increased dramatically. I have a number of 140 in 2010, up to 4,199 into 2012. That's a significant number of audits. Now, the audits themselves are basically given that facility 45 days to report all information to basically show medical necessity. And, you know, obviously their payment or actually taking back the payment would be based on that information. Having been a nurse for over 20 years, I know working in a physician's office that, you know, you are dependent upon that particular physician's office to, you know, provide that information, and then the facility or the company that's provided the durable medical equipment is then incumbent to report the information to you. In this current state of healthcare, with fewer physicians and physicians having to decrease their overhead, that's a big problem. What are you doing today to help decrease this cost of administrative costs to these not only durable medical equipment companies, but also to physicians who are also facing this burden?
As you know, Congresswoman, durable medical equipment has been an area that's been subject to serious fraud in the past. It's one of the highest risk areas.
But, sir, if I could interject.
But I will say,
one of the issues that we were delineating here is between improper payments and then fraud. A signature or a date or an order is simply not fraud. So having really identified that already, how could a company be required to send back reimbursement, or a physician's office be required to send back reimbursement, and then have to go into an appeal process that could take up to 14 to 24 months for that payment? Isn't that a little excessive?
So if there's a specific circumstance that you'd like us to look into, to get the details, I'd be delighted to do that. I can tell you that this is an area where we do need to be sure that the durable medical equipment has been appropriately ordered by someone who is qualified to order within the Medicare program, and that there's documentation for that. That's the legal requirement. If there's an individual circumstance that appears to be somewhat of a problem, why don't you contact us, and we'll be delighted to get that information from you, and
we will definitely do that.
Where things stand.
I am over my time, so thank you very much. I thank the chairman for indulging me.
Chair thanks, gentlelady. Now recognize the gentleman from Texas, Mr. Hall, for 5 minutes for questions.
Thank you, sir. Mr. Bedetti, you mentioned the recovery audit contractors, the RAC, how you're expanding that program into Medicaid. And I appreciate the fact that you and all the money you save the government, all the fraud that they detect, and I see you as necessary with the abuse that abounds. And I have kind of a follow-up from the questions of Dr. Christensen and Council McKinney. I have a company in my district that's been accused of owing multiple millions of dollars back to the government because the RACs claimed that some of the services they provide were unnecessary, just some of the services they were. They're now working with CMS on a payment play that they can afford if they ever get in front of a judge. And lawyers, and I also note that that RACs are paid on commission. Is that correct?
The RACs are paid on a contingent fee basis, yes, sir. So they only get to.
Well, you know, that's one of the things that kind of got lawyers in trouble, and probably brought about the tort reform. They'd file cases that with little merit, but an insurance company would pay it to keep them, save money by paying it and not having to go to court. And it's brought a lot of criticism for lawyers. I'm a lawyer, but I remember a story, if I might tell it. You know, in Orlando, if you've gone there, you know, you land in the airplane and you get on a train and you go on into where the tickets are made there, Orlando. And going there, the doors will close on you if you're not careful. And just before they closed one time, a guy hollered, I want you to know that I'm a lawyer, just got my degree last Monday night, and then the doors closed and they went on down the track. Somebody said, I hate lawyers, they're all geeks. And another guy in the crowd said, I resent that. And he said, well, I'm sorry, I didn't mean to offend you. I didn't mean to say anything about law. He said, I'm not a lawyer, I'm a geek. So but something brought about bad things in the tort reform. Sometimes you can overdo that. So I guess what I want to really ask you about, you acknowledge that part of your role is to strike an important balance to protect beneficiary access to necessary health care services and reduce the administrative burden on legitimate providers. I like that, while ensuring that the taxpayer dollars are not lost to fraud, waste, and abuse, and I certainly support that. But what are some specific concrete steps that CMS could take to work with legitimate providers who may inadvertently find themselves ensnared by some of these anti-fraud initiatives? I think there's a huge distinction that should be made between a provider who's committing fraud, for example, billing for services that weren't rendered, and just plain making a mistake. And that's the situation I have in East Texas, where they've been called upon to make payments that they're unable to make now. And if they're not able to get to the legal service that can't reach them for over a year, they have nothing to do but to shut their doors. And they provide a very wonderful services to people, and they might have made a mistake, but they need a way to pay their way out of it or prove that they didn't make a mistake. And since y'all are paid on commission, you're going to be filing those. And I don't say that you just file anything that comes in the door, but if you don't file them, you're on a commission basis. You don't make any money if you don't file. Do you think this is the best way to pay these contractors?
Sir, the contingent fee approach, of course, is a statutory requirement of the program.
I know you didn't devise it.
So
We
we're
devised it probably, but what do you think about it?
But I will say that as I said before about all of our programs, we want to get it right. And I think that one of the things that we are doing is greatly increasing our feedback to providers about exactly what the findings from the RAC program are and what steps they can take to assure that they have the appropriate procedures in place in their billing and appropriate documentation and appropriate site of service, so that we're giving them feedback, we're giving them comparative reports, we're giving them indications of what the RACs are finding and what the underlying data are behind what the RACs are allowed to look at by CMS. So we agree with you. We want the outreach to be even more successful in terms of educating the provider community. And we also want to be responsive to any specific problems like that. And so again, sir, if there's something that, a specific issue that you'd like us to look into, we'll be happy to do that. But we are building as much feedback as we can to try to make sure the program works as well as it can.
But the alternative is to go to the courthouse, and these people can't get to the courthouse for a long time because of the loads of the particular area, the courts. So maybe I would like to talk to you sometime about them. My time's over. I thank you.
Chair, thanks, gentlemen. That concludes the first round of questioning. We'll go to one follow-up per side. Dr. Burgess, you recognize 5 minutes for a question.
Thank you, Mr. Chairman. I think anyone who's watched this hearing this morning gets a sense of the enormous amount of time involved in all of these things, and what people have a hard time understanding is why it does take so much time. It takes the General Accountability Office a little over a year to do a study, to deliver that back either to the legislative branch, where that it takes us time to come up with a legislative fix, or to the agency. And we see 3 years into the signing of the Affordable Care Act into law, 1 out of 7 of the anti-fraud provisions have actually been enacted. Not to say that you're not working on the others, but 3 years does seem like a long time frame. And I don't know what can be done to accelerate the process. I know when GAO gets a request from us, they want to do a good job. It does take time, but somehow we need to make this all work and work to the extent that we're not just delivering money to to organized crime. Let me just ask one last question to Dr. Budetti. To what extent are HHS and CMS using commercial public record database services, such as those used by banks and retailers, to verify the identity of providers and beneficiaries before claims are paid?
So we've put into place and are building a system that will be even more extensive than it has been in the past in terms of getting access to a variety of databases, such as the ones that you referred to, in order to verify the provider and supplier information and to identify them. That's part of the automated provider screening systems capabilities that we are continuing to build out, and it will allow us to look not just at licensure and Social Security death files and other things, but also at a wider range of databases that we will have access to, and the system has been is being used in specific ways right now, and it will be phased in as the core way of enrolling providers. So on the enrollment and on the revalidation side, we are very definitely moving in that direction, and we've already made a great deal of progress.
I assume at some point in the future it's going to be linked to payments and billing as well.
The fraud prevention system and the automated provider screening system are specifically designed to be able to interact and talk to each other, if you will, so that the information we get from the one side can feed into the other side. And so, yes, that is exactly the way that this is intended to operate.
Again, the credit card companies figured this out 25 years ago. It seems like we ought to be farther along than we are now. Thank you, Mr. Chairman, for calling the witnesses. I'll yield back my time.
Chair, thanks, gentlemen. Now recognize the ranking member, Mr. Pallone, for a follow-up.
Thank you, Mr. Chairman. I wanted to ask Ms. King, we've heard in the past recommendations that CMS pilot or adopt certain technologies like smart cards, and I think Mr. Shimkus actually mentioned this. But since much of GAO's work centers around making sure that the government is prudently spending taxpayer dollars, I'd like to ask you from the GAO perspective, what questions should CMS be asking before embarking on any activity that would give tens of millions and even billions, perhaps, of dollars to a handful of companies in one industry to create this technology? What would you recommend?
Mr. Pallone, we've actually been asked to look into smart cards, and we have a request in-house that we hope to start soon. And I think from that, we should be able to answer some of those questions, like what are the costs and benefits, what are the risks, what are the downsides to this? Because, you know, right now, as you know, Medicare has a paper card that displays a Social Security number, and we have recommended in the past that that be taken off of there. And CMS has estimated about $800 million to do that. We don't think that that estimate was credible, and we asked them to do another one. But certainly any smart card effort would cost much more than replacing a paper card. So you're raising very legitimate questions, and we will be looking into it and advising both CMS and the Congress, we hope, later this year.
Thank you. Can I ask Dr. Budetti, is there anything else that the committee or Congress should do to help you in your ongoing efforts or activities, if you just wanted to comment in general?
So, Mr. Pallone, I appreciate the question, and I have to say that we very much appreciate the support that the Congress has given us, and this is something that I think everybody agrees is important. And so we will be delighted to continue to work with all the members on any ideas or any potential improvements that might come up. But we very much appreciate the support and the interest that's being shown in fighting fraud, waste, and abuse, because we all agree this is a very important aspect of these programs. So thank you, Mr. Chairman, and thank you, Mr. Pallone.
Thank you and the whole panel, and I yield back, Mr. Chairman.
Chair thanks gentlemen. Chair thanks the panel for your testimony, for answering questions. Been very informative. And at this time, we'll dismiss panel 1 and call panel 2 to the witness table. And I'd like to thank the second panel for agreeing to testify before the subcommittee today. And I'd like to quickly introduce our second panel as they come to the table. First, Mr. Darrell Langlois, Vice President of Compliance, Privacy and Fraud at Blue Cross Blue Shield of Louisiana, and Mr. Thomas Green, Managing Partner of Green LLP. Again, thank you all for coming. We have your prepared statements, and they will be made a part of the record. Mr. Langlois, will begin with you. You're recognized for 5 minutes to summarize your testimony.
Thank you, Mr. Chair. Ranking Member Pallone and subcommittee members, I am Darrell Langlois, Vice President of Compliance and Privacy and Anti-Fraud Activities with Blue Cross Blue Shield of Louisiana. It's my pleasure to be here today to talk about a very important issue. And as I listen to the testimony and the conversation leading to this point, I want to tell you that healthcare fraud has far more reaching implications than simply the money and the dollars that are taken out of our system. And I would like to emphasize my testimony today on the fact that many times, and at an alarming rate, we find that the healthcare fraud that takes place is beyond the dollar, and it is impacting the patients, your family, my family, in ways that are unmentionable. And that is through the quality of care that is received that ultimately results in patient harm. In my 20-plus years of being in this field, working both nationally and locally, I can tell you I have been increasingly alarmed at what I have personally seen in my own state in cases that I have worked personally. These are not anecdotes. These are not stories read in the Wall Street Journal. These are stories and cases that I've worked personally. And it alarms me and concerns me, and I hope we talk a little bit about that today. My testimony is going to touch two broad topics. First, what my organization has done in this regard, and second, how the Affordable Care Act's MLR provisions are serving to limit and hold back some of the investment that could have and has taken place in the past in respect to healthcare fraud. First, as far as my organization, we have structured a three-point strategy. It has evolved in the 20 years that I've been responsible for healthcare fraud at my organization and is currently in this format. First, we believe that data is at the foremost and the forefront of what we must do. The implications, the indications, and the analysis that must be done through data is apparent and foremost. The technology that is needed to ensure that we are successful in almost every turn in this regard is growing and evolving, and some of it is there and available for us, but we do need to see improvement in that area, and we need to spend money in that area, and we need to increase resources in that area to do some of the things that I think Representative Burgess and others have talked about in relation to other industries, how they've been more timely in that respect. The second is public and private partnerships. I have been very fortunate to work very closely with the law enforcement entities in my state. I could name names, go on and on. But we have been one of two plans around this country that has been successful in being included in the government's HEAT cases there in the state of Louisiana, and that is a direct result of our willingness to work hand in hand with our public partners in this healthcare fraud fight, and we think that needs to continue. Finally, prepay is an avenue in which we must continue to follow. The pay and chase model has long been gone, long deemed unsuccessful, and I'm proud and appreciative of the comments I've been hearing today that that is something that no one is considering to be a success and no one is considering to be a strategy on a go-forward basis. We must keep the dollars out of the hands of those who are willing to defraud our system, and the best way to do that is to never pay the dollar in the first place on a prepay basis. The second part of my testimony is to address the MLR provisions of the Affordable Care Act. Today, as we understand it, only the recovery portions of what a private payer is able to recover are provided to us as a benefit in that calculation. As we just said, prepay is where the strategy needs to be and where the focus needs to be. So to have a calculation that focuses on an antiquated or towards a strategy that no one wants to employ anymore seems to be something that we ought to consider changing. In that regard, we would offer that we broaden the perspective of what is allowed in this fight against healthcare fraud to something that's more than recoveries. Also, again, as I started my testimony, I mentioned to you that my alarming and concern that I've seen in my 20-plus years of this has been around the quality of care issue. I can tell you about cases where patients have died. I can tell you about cases where I've spoken to family members who've had their family members irreparably harmed physically as a result of what physicians or other professionals have chosen to do in the name of seeking money. That is something that comes about through investigations and not solely in the quality improvement arena. And I'd encourage strongly that the committee and Congress considers that those are the things that improve our system and should be accounted for in our medical loss ratio. That concludes my comments, and I'll be prepared for any questions you may have.
Chair, thanks, gentlemen. Mr. Green, you're recognized 5 minutes for opening statement.
Well, thank you, Chairman Pitts, Ranking Member Pallone, and members of this.
Is your button pushed? There. Yeah, I'll just.
Is that better?
That's better. Thank you.
Thank you, Chairman Pitts and Ranking Member Pallone, and members of this committee for inviting me to testify on innovations to fight fraud, waste, and abuse. My name is Tom Green, and my testimony today relates to my experience representing whistleblowers under the False Claims Act for more than 20 years. The vast majority of my False Claim Act cases have been in the healthcare industry. With respect to pharmaceutical marketing fraud litigation, I've also represented private payers, including health insurance plans, Taft-Hartley funds, and self-insured employers. I'm pleased to be here today to speak about the False Claims Act, which is an excellent model of how the United States can foster innovation in fighting health care fraud, waste, and abuse. The False Claim Act is a dynamic fraud-fighting machine which encourages the participation of insiders with knowledge of fraud in the government. That's really good for everyone. And because whistleblowers can pursue cases even when the United States does not intervene, the False Claims Act can foster new ways of fighting healthcare fraud. When I first filed what was the first off-label promotion False Claims Act case in 1996, government attorneys were not convinced of the viability of that theory and declined to intervene. But once that case was settled in 2004, it set a precedent that kicked off $14 billion in other recoveries. All told, since 1986, more than $24 billion has been recovered by the government for healthcare fraud cases under the False Claim Act, thanks largely to courageous whistleblowers who often risk their own financial security. Today, I make 3 recommendations to improve the effectiveness of the False Claims Act. One is to clarify the pleading standard for such cases, because many courts have applied the standard for common law fraud. A second would be to do more to encourage states to enact False Claims Act. And there's one more thing that Congress could do by addressing one impediment to investigation and pursuit of False Claim Act cases that attorneys in my position find particularly troubling. Although we're working on behalf of the United States when we pursue these cases, it's often very difficult to gain access to data from CMS. Such data can be critical to proving a False Claims Act case because many whistleblowers are in marketing, sales, or servicing, and it's unusual for them to already have the data in hand when they come to the attorney. Some of these cases fail not because the fraud is uncertain, but because we can't get CMS data. Frankly, it's ridiculous not to facilitate our access to CMS data when billions of taxpayer dollars hang in the balance. Marketing fraud by pharmaceutical companies accounts for more than half of the healthcare money recovered under the False Claims Act, especially through off-label promotion of drugs. False or fraudulent off-label promotion is a serious problem which costs taxpayers billions of dollars through the payment of increased health insurance premiums. And this serious problem needs to be addressed by Congress, in part because private payers don't have a fraud-fighting tool as potent as the False Claims Act. Now, I believe that fraudulent pharmaceutical marketing can be stopped before it starts in 5 ways. First, fraudulent pharmaceutical marketing could be deterred by giving private payers a right of action, because currently they're left to use ill-fitting options like RICO or patchworks of state laws. Second, marketing fraud can be deterred by giving teeth to the FDA Amendments Act clinical trial registration requirement. Third, it could be deterred by threatening the forfeiture of Hatch-Waxman Act patent extensions for particular drugs. As you know, these extensions are granted in part for cooperation with the FDA approval process. When drug companies do end runs around the FDA through off-label promotion, drug companies should forfeit these extensions. Fourth, pharmaceutical marketing fraud could also be deterred by making sure that pharmaceutical executives have some skin in the game, personally. And lastly, I'd like to recommend that Congress eliminate the incentives for medical device manufacturers to play games with the 510(k) approval process, which could be done by amending the Social Security Act to forbid reimbursement of off-label medical devices, except in certain circumstances. Now, I'd be happy to expand on any of these issues that I've commented on this morning, and there's additional detail in my written testimony. I'd like to thank you, Chairman Pitts and Ranking Member Pallone, for this opportunity to testify, and I'm glad to respond to any questions that you might have.
Chair, thanks, gentlemen. I will now begin questioning and recognize myself 5 minutes for that purpose. Mr. Langlaw, your testimony describes many of the important investments plans to prevent fraudulent payments and improve quality so you can attract customers. I'd like to ask you to expound on this some more. If a plan expands its provider network based on their customers' desire to receive care from a particular doctor or physician practice, does the MLR classify the associated cost as an administrative expense? And doesn't this penalize a plan for expanding consumer choice in doctors and providers?
It is my understanding that that is an administrative expense, and as such would have to factor into the overall cost of our products and the overall cost of health care, which would serve, as the costs go higher, would serve to limit choices for our customers and those who participate in the program.
Now, plans often work to ensure that healthcare practitioners are properly credentialed to provide care. Are these quality-enhancing activities punished by the MLR rule?
Again, it's my understanding that those are considered administrative costs, which do not benefit that calculation and would serve to discourage, to the extent it doesn't make reasonable sense to the organization, it would discourage them from participating in that activity at some reasonable level.
So it would penalize a plan for ensuring credentialed providers are serving their customers.
Yes, sir.
Now, these are necessary and non-negotiable costs that we all want to encourage health plans to incur, and clearly are not the kinds of costs that Congress wants to curtail. Network expansion and credentialing providers are critically important and beneficial to customers, to consumers, and clearly enhances value for their premium dollars. I'm not sure, but why is HHS classifying these expenses as administrative when they're expended specifically to improve the quality of a network that a patient can access?
I'm afraid I don't have the answer to that question, as I did not participate in the process.
Now, in your testimony, you write that, quote, the MLR regulations treatment of fraud prevention expenses works at cross purposes with efforts by the federal government to emulate successful private sector programs, end quote. Could you expound on these comments?
Sure. As an organization under the current MLR calculation chooses to spend money or not spend money, as it works today, if they choose to spend money and invest in this critical function, every dollar they spend works against them in the calculation of the MLR. Therefore, a choice has to be made according to many factors by those who are, have the opportunity to spend that money, and they have to make it in spite of the fact that it's going to work against them in the MLR calculation, knowing that it could be better for the organization and its members to go ahead and invest in the money. My recommendation, of course, would be to take away that cross-purpose and make it a dual win-win. Let's not only spend the money in a manner that's beneficial to the system and for our customers, but let's also let it work for us during the MLR calculation, which serves to better our system overall.
Now, there remains significant interest in Congress about anti-fraud efforts in Medicare and Medicaid. We just heard from the administration that fighting fraud in Medicare was a key goal of the administration. Yet, the MLR regulation excludes health plan investments in initiatives to prevent fraud from those activities that improve health care quality. Does this create a perverse incentive in the commercial insurance market to tackle fraud on the pay and chase side rather than the prevention side, just at a time when CMS is stepping away from the pay and chase model?
It certainly seems that way. Again, as I testified a few minutes ago, recovery processes are the old way of doing things, and for the calculation of the MLR to only afford a benefit in that regard does seem to be outdated and something that should be seriously considered to be changed. That is by far a method and an approach that my peers in this industry are going away from as quickly as possible for many reasons, but certainly I think that should change in our calculation.
Finally, members from both sides of the aisle have stated that Congress should promote policies that encourage young people to purchase health coverage. However, doesn't the MLR penalize enrolling young and healthy individuals in a health plan, since doing so makes complying with the MLR standard more difficult?
If you consider from the perspective that if the MLR calculation continues as it is, and that continued investment in fraud or the lack thereof allowing fraud to further be perpetrated and to a larger extent, that will serve only to increase the overall cost of healthcare fraud. And we know that that is the primary factor for the young in which to engage and participate in the health system. So for those reasons, as you mentioned, I would say the answer is yes.
Thank you. My time has expired. Chair recognizes the ranking member, Ms. Pallone, 5 minutes for questions.
Thank you, Mr. Chairman. Question for Mr. Langlois. You spoke in your testimony about concerns about the way anti-fraud activity is counted as part of the Affordable Care Act provisions for calculation of the MLR. But didn't NAIC, the National Association of Insurance, well, let me ask you this. The administration felt like it was taking a balanced approach in this, giving credit for dollars recovered, but not for fraud prevention activity. And based on information on the Blue Cross Blue Shield of Louisiana website, it looks like your return on investment for fraud-related activity is on the order of 10 to 1. So didn't the National Association of Insurance Commissioners, didn't they support this compromise regarding fraud and abuse work at the MLR?
I'm not sure I understand.
The NAIC, which is the National Association of Insurance Commissioners, they supported this compromise, the idea that, I mean, I'm asking you if they did, my understanding is that they did, that, you know, we take this balanced approach where you give credit for dollars recovered, but not for fraud prevention activity. And my understanding is that they supported that balanced approach. Is that true? And is that a factor in the fact that you had this high return on investment for fraud-related activity?
I think I have two responses to the question. First of all, I have worked somewhat with the NAIC on an unofficial basis. We happened to be at the same location, and a gentleman was speaking on this very issue, and I made the same comments that I'm making here today to him and asked if there could be reconsideration. I'm not aware and did not participate in any request for it to be a balanced approach and that this was the result of that. But I will say that in my speaking directly to the NAIC on this matter, I've echoed the same comments I've made today. They seemed receptive, but of course indicated that there would have to be further evaluation before any changes could be made. As to the dollars that you reference on our website about our activities, Those dollars are largely not on a recovery basis. Those dollars are largely saved on a prepay basis and depends from year to year. Times and cases and situations will adjust to be flexible from year to year, but the recoveries are not solely represented by the number that you did. Those are a function and aggregation of all savings that our office works towards.
Well, let me ask you this. Has Blue Cross Blue Shield of Louisiana had to cut back on any of its anti-fraud activities as a result of the MLR requirements? Have you had to make any cutbacks?
Could I ask you to ask the question one more time? I missed the first.
In other words, has Blue Cross Blue Shield of Louisiana had to cut back on any of its, basically reduce any of its anti-fraud activities as a result of the MLR requirements?
The word cut back would seem to include
or reduce,
to reduce.
Yeah.
And I would say that where we are, if we have held steady, the organization has recognized since 1990 the healthcare fraud is a problem, and as such, its investment has held steady. But as I mentioned earlier,
but then you haven't had to cut back or reduce as a result of that requirement.
we have not been allowed to go forward. We have not cut back, but we've not allowed to move forward with investments that are necessary as the technology increases. And we've been looking at technology that is something that we believe were needed, but has been unable to move forward at this point.
I mean, I'm just trying to point out that the NAIC, which represents the nation's insurance commissioners, agrees with the current MLR calculation with respect to fraud. Let me issue one more thing on the. I was excited to learn about your participation in the Healthcare Fraud Prevention Partnership being led by the Secretary and the Attorney General. And are there any activities being undertaken by CMS that you think have been particularly helpful or supportive of your efforts? Let me issue that.
Actually, there was one initiative that I was a participant in with a small number of people that I looked upon very fondly and was very hopeful that the process would carry out. As you might imagine, there are times when CMS recognizes that a provider is engaged in an activity that's worthy of their attention, and so they'll place a stop payment or a hold on that provider until they can better determine what is taking place. There is a ton of Medicare supplemental private products that are on the market, of which my organization also sells. When CMS previously was stopping these payments, we were not made aware. So a payment claim filed by a provider may not have made its way through CMS, but was being passed on to us as the private supplemental payer, and we were unaware of the activity that was taking place. There was an initiative that was begun to where that information could be shared, and as a result, that provider would not see payments that could have potentially been fraudulent either from CMS or us. And I was very appreciative and fond of that process. Unfortunately, I think at this point the process hasn't made its way to fruition, but we're hopeful that it will. And that was one that I very much look forward to.
All right, thank you. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the Vice Chair, Dr. Burgess, 5 minutes for questions.
Thank you, Mr. Chairman, and Mr. Langwell, and Mr. Green. Thank you both for being here today. Appreciate your time spent in the committee. Let me ask you, as a representative of a private insurance company, I mean, you've heard the discussion of the size, the number of dollars that are involved in at CMS and fraudulent or inappropriate transfers of funds. Do you have anything approaching that in the Blue Cross Blue Shield world?
As to an evaluation of what those numbers are, unfortunately, the best measure we have at this point is we work very closely with the other anti-fraud activities around the country, both at the private side. We also recognize the CMS side, and we measure our success according to what we're seeing other payers execute in the anti-fraud world. I get asked the question a lot, and I know it's maybe not the greatest of answers, but I would tell you, do we know at any particular time how many people are speeding down the interstate? And the answer is we don't, but we know it's happening, and it's impossible to gauge that. So I don't have that, but I can tell you that the returns on investments that we've been turning in the last 20 years has not slowed down, has increased. And again, I would just emphasize the stories and the cases we're seeing around quality have really brought an alarming sense to us.
Give us a sense of what you're talking about there. Can you give us an example?
In the quality?
Yes.
Real quickly, there are 3 cases that recently resulted in the state of Louisiana. The first was a cardiologist who, in the name of money, was placing stents in patients who had no business undergoing a knife or any surgeries at all. We testified this was a great public-private collaboration. We as a victim were brought in this case. The government was brought as a victim in this case. We both testified, and the cardiologist recently was ordered to head to prison just before Christmas of 2012. There were millions of dollars involved, and as I spoke at a meeting in that area, I had a family member step up and said, I just wanted to let you know that my brother was one who was unnecessarily operated on and was now irreparably harmed. This was not identified in a quality improvement program. This was not identified by a group of nurses who sit in the back of a particular area and work on a diabetic approach or something. This was identified through hard-nosed investigations efforts, both at the public side and the private side, and we brought to bear that. In another example, we had an...
Let me stop you there for just
Sure.
a second, and I do want to hear your second example. But in the private insurance world, somebody's going to call a 1-800 number somewhere and get pre-authorization for that procedure, are they not?
Yes, and in this instance, the cardiologist was willing to provide the information that would make that appropriate yes answer on the pre-authorization. He was capable of giving the information that made that appropriate, when in fact the information was not accurate. He owned not only the cardiology clinic, but he owned the lab in which those diagnostic type procedures
Where the studies were done.
justified the surgery in the first place, and he forged that information and necessary to make the surgeries happen.
Well, do you feel that that is something, I mean, was this just a one-off where one person is performing this, or do you feel that there's a larger problem there?
No, you will find, if you read the literature amongst the government, healthcare fraud, and you talk to others. I believe previous testimony was heard by Alana Lavelle at WellPoint. She spoke about cardiology and stent procedures in her world, and she does not do business in Louisiana, so clearly this is not a perception or a one-off situation.
And what have you done as an industry to more carefully define and refine that so that you not only prevent the inappropriate transfer of funds, but you also prevent the inappropriate delivery of care? I mean, basically, that's upselling someone who came in with a problem that was not of cardiac origin, who then got a cardiac procedure. Am I correct?
Correct. The use of data analysis, again, the 3 points I talked about earlier, use of data analysis, the direct collaboration with the federal government, and reviewing things on a more prepayment basis, and refining those. We talked about, I was asked the question, have we cut back? We haven't cut back, but of course we haven't extended forward the way we want to. If I were still doing the things 20 years ago that I'm today as I was doing then, I wouldn't be success. We've had to evolve and move forward, and not being able to do that is some ways hurtful.
Give us quickly your other example that before I stop
Another
you.
example, of course, this is throughout the country and probably throughout the world, but we had an internal medicine practitioner who was willing to dole out OxyContin and various other controlled substances to members, despite in his own practice he had newspaper articles that articulated that his patients were distributing the same drugs he was prescribing on the street, yet he continued to prescribe those drugs. There were at least 8 deaths associated with overdosages and other things, to the point that one of his patients actually sold the drug to another individual who died as a result. So it wasn't even a patient of that doctor, yet death followed his prescription onto another unsuspecting individual. That individual has currently lost his license and is serving 16 years in federal prison. Again, another collaborative effort between public and private, not identified in a quality improvement arena, rather identified in an investigation angle, but certainly taking a bad doctor out of the system that we all had to pay for.
Yes, sir. Thank you, Mr. Chairman. I'll yield back.
Chair thanks gentlemen, and now recognizes the gentlelady, Dr. Christensen. 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Green, I wanted to ask some questions around your testimony. Since 1986, over $35 billion, I understand, has been recovered through the False Claims Act for the government, and the majority of those recoveries come, as you've stated, as a result of whistleblower-initiated cases, healthcare-related recoveries from pharmaceutical companies, hospitals, and clinical laboratories. Can you give us a few brief examples of what some of the kind of fraud were involved in those cases? And What other kind of cases, other than the pharmaceutical, which you said represented the vast majority of dollars, what other kinds of cases have successfully returned money to the states or federal government?
I can, and I touch on this in more detail in my written testimony, but I can summarize here. First, I'd like to say that the majority of healthcare recoveries under the False Claims Act come from whistleblower-initiated KETAM cases, rather than cases initiated by the government. The KETAM cases outnumber the ones initiated by the government by 5 to 1. Healthcare cases under the False Claims Act come in many different forms. You might have a hospital or nursing home that upcodes claims to get higher reimbursements, or for billing services that were not actually performed. Testing labs cause billing for unnecessary lab tests, or again, for tests not performed. There are cases that are based on violation of the anti-kickback statute or the Stark Law, where physicians are getting illicit payments or benefits for lucrative self-referrals. Durable equipment companies bill for equipment that was never delivered. And you can have medical supplies companies that can be the basis for actionable fraud. One of my cases was actually just recently unsealed. It involves unnecessary delivery of oxygen supplies. So really, there are many different types of cases. Somebody usually sees this fraud occur, and sometimes someone will step forward and blow the whistle.
You know, and while the False Claims Act specifically deals with getting money back to the government, it seems to me that private payers, insurance companies, employer benefit plans can be equally victimized by these fraudulent practices, and I think we've heard some of that already in the testimony. Can you please elaborate on how private parties are affected and what recourse they have at this time?
Well, start off by saying private payers don't have the potent tool, the False Claim Act, that the federal government has. But yet they can be the victim of frauds. They can be the victim of medical tests or products that are ordered as a result of kickbacks. Really, what they're faced with, the only thing they can rely on really are a patchwork of state laws or RICO claim, and those are imperfect. If Congress would consider passing a private right of action that might give private payers like Blue Cross sitting here at the table an opportunity to recover the costs that they spent as a result of fraud. But as I say, it's been difficult to try to put together a large group of health insurance plans across the country to bring these cases in the form of class actions. Courts are not always receptive to that, again, because of the patchwork of state laws that these claims are brought under, or RICO. I think if we had a private right of action for third-party payers that perhaps offered double damages and an attorney fee-shifting provision, that would begin to give private payers the tools that they would need to recover some of the monies they've lost as a result of fraud.
And Mr. Langlois, I think you've answered most of my questions around MLR and the private-public partnership. I don't know if you wanted to comment on the last question around False Claims Act not, being an avenue where a company such as yours might be able to recover.
It's a great question, and I appreciate you bringing it up, and I respect Mr. Green for his attempt to benefit us. We identified 2 years ago in my state, particularly myself and a senator of Louisiana, state senator, the need for this. And we, in the last legislative session, actually passed a False Claim Treble Damage Act provision at the state law level that allows, whenever I am a victim of a healthcare fraud, to bring about damages and penalties to those who do such, similar to the federal level. Now, the way it works, and I won't belabor this point, but the way it works is I retain the monies that I was a victim of and lose. The second and third level of payment from the treble damage calculation returns to the state in its effort to fight and better fund healthcare fraud efforts. So I very much appreciate the point he made, and I do think that there's opportunities there.
Chair thanks gentlelady. Now recognize gentleman for Virginia, Mr. Griffith, 5 minutes for questions.
I guess my concern relates to the lawsuit type, and Mr. Green, I'm going to ask you. I know you're trying to ferret out people who are doing things that are just fraudulent outright, but don't you think it might have a chilling effect on those folks who are using an off-use or an off-label use in cases with patients who might have severe illnesses such as AIDS, rare diseases, cancer, et cetera? Don't you think that if you take that too far, that you can actually hurt some of the patients who may need an off-label use?
Well, I think what you're pointing out, and I recognize, and of course courts recognize, that physicians have and will always have the right, based on the exercise of their independent medical judgment, to prescribe a drug for an off-label use. There's nothing wrong with that.
But here comes the question that based on your written testimony, the question then becomes, though, that what, as I understand your testimony in your written form says is that if a company, though, has a study that says you can use this for a rare form of cancer and that some doctors have found it successful, that they may then open themselves up. If the pharmaceutical, because if I'm treating somebody in Abingdon, Virginia, I may not know that somebody in California or New York was successfully using another physician was using an off-label drug to successfully treat this particular condition or disease that may be very severe. How am I supposed to find that out if the pharmaceutical company is barred from sending out the information?
Well, they're not barred from sending out the information, Doctor. There are
I'm not a
guidances.
doctor, and I'm a lawyer, but whatever.
Oh, I'm sorry. There are guidances and guidelines that allow the dissemination of scientific articles. What I'm talking about is fraudulent promotion of off-label uses. What I'm talking about is when a drug company comes up with a marketing strategy that's signed off by the president of the company, as was the marketing for Neurontin, that they're going to do an end run around the FDA approval process, and they're only going to publish positive results, not negative. So we're talking about fraud. We're not talking about interfering with a physician's right to prescribe off-label. We're not talking about with a drug company's right to disseminate truly scientific articles that talk about off-label uses, provided they comply with the safe harbors.
All right. And I appreciate that and understand the distinction. Now, one of my, as I was reading this and listening to it, one of the things that I noticed was you talked about how much money was recovered on the Neurontin, is that how you say it?
Yes, that's right.
I'm just curious how many folks were negatively impacted. Were there deaths? Because I'm not familiar with that.
I don't have the
okay. Were there deaths?
The answer to that question.
Do you know if there were any deaths? There were.
There were. Keep in mind, with regard to Neurontin, the FDA, it was approved for adjunctive therapy for epilepsy in December of '93. And the FDA told the company back in 1992, when they looked at the clinical trial data, that it showed that the subjects were suffering from depression, suicidal ideation, and it could lead to suicide. And the FDA told the drug company that this drug will have a limited, widespread usefulness, but they approved it as adjunctive therapy for epilepsy. What did the company do? It turned around and it marketed it to bipolar patients. That was off-label, and they never disclosed what the FDA had pointed out to them about it.
So as long as you send out the positive and the negative, you're not against pharmaceutical companies from sending out articles that highlight that this might also be helpful in some other disease area, but that, you know, here's what we've got thus far.
Provided they comply with the safe harbor guidelines.
All right.
There is, they can do that. They can disseminate truly scientific articles that describe accurately the results of their clinical research. The FDA has given them a safe harbor to do that. That's not fraudulent promotion.
All right. I think I have 30 seconds if anybody wants it. I yield back.
Chair thanks the gentleman. Chair thanks the second panel for your testimony. And I remind members that they have 10 business days to submit questions for the record, and I ask the witnesses to respond to the question promptly. Members should submit their questions by the close of business on Wednesday, March 6th. Without objection, the subcommittee is adjourned.